Welcome, everyone. I think we'll get started so that we can get as much out of this webinar as we can in the next hour. The University of Toronto Joint Centre for Bioethics is pleased to host the 8th annual Ross Upshur Lecture on Public Health Ethics. My name is Max Smith. I'm an assistant professor of public health ethics and health policy in the Faculty of Health Sciences at Western University. And as a former doctoral student of Dr. Upshur's, I'm honored to be the moderator of this exciting lecture. The Upshur Lecture on Public Health Ethics is a lecture that studies all aspects of public health ethics. Public health ethics affects everyone at local, national, and international levels. This lecture seeks to study the ethical problems which arise in public health and preventative medicine from both theoretical and practical perspectives. And isn't it an opportune time to be exploring tensions in public health ethics as we are experiencing a devastating third wave of the COVID-19 pandemic here in Ontario, a pandemic which, no matter where you look, has raised some profound ethical challenges. Ross Upshur was director of the University of Toronto Joint Centre for Bioethics from 2006 to 2011, and was involved as a member for many years prior to that. During his term as director, Ross increased the JCB's public engagement impact with the World Health Organization. The JCB is the original PAHO WHO Collaborating Center for Bioethics, and under Ross's leadership, the JCB helped to form the WHO Collaborating Centers for Bioethics Network, where the JCB was the inaugural chair of the network. During this time, the JCB also hosted a WHO meeting on tuberculosis and provided the WHO with extensive support during the SARS epidemic. Ross's research has covered many aspects of public health across the life course, and his extensive research has helped to shape the JCB in many significant ways. And I'm very pleased to say that this is not a memorial lecture. Ross is, of course, remains a seminal figure in public health ethics, including through his current work as the co-chair of the World Health Organization's Ethics and COVID-19 Working Group. Before we get started, I'd like to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. We're honored and privileged to have three leading figures in public health ethics contributing to the Upshur Lecture this year. I'll introduce all three of our panelists, and then I'll turn to each for their initial remarks of around 5 to 10 minutes, each which will then be followed by a discussion period. Our first panelist will be Sally Bean, who is the Director of Ethics and Policy at Sunnybrook Health Sciences Center. Her educational background is in law, bioethics, and public policy. She's an adjunct lecturer in the Dalla Lana School of Public Health and the Institute of Health Policy Management and Evaluation at the University of Toronto. In addition, she is the ethics member on both the Ontario Health Technology Advisory Committee and the Canadian Drug Expert Committee, which is part of the Canadian Agency for Drugs and Technologies in Health. Our second panelist is Dr. Brian Schwartz, who is Vice President, Science and Population Health at Public Health Ontario. He also currently serves as co-chair of Ontario's COVID-19 Science Advisory Table, which provides scientific advice to inform the Ontario Ministry of Health response to the pandemic. Previously, Dr. Schwartz served as Vice Chair of Ontario's SARS Scientific Advisory Committee in 2003, chaired the Provincial Scientific Response Team during the 2009 H1N1 pandemic, and has played a leadership role in preparation for events such as the 2010 G8, G20 summits and the 2015 Pan-Para-Pan Am Games. He also serves on pandemic planning and response tables at a national level. Dr. Schwartz has published extensively in the field of health emergency management and is an associate professor in the Department of Family and Community Medicine and the Dalla Lana School of Public Health at the University of Toronto. Finally, our third panelist is Professor Alison Thomson, who is an associate professor in the Leslie Dan Faculty of Pharmacy and Dalla Lana School of Public Health and a member of the University of Toronto Joint Centre for Bioethics. She's a visiting fellow at the Institute for Advanced Studies at Ludwig Maximilian University in Munich and a member of the German COVID-19 Competence Network Bioethics Group and member of the Ontario COVID-19 Bioethics Table. Her interdisciplinary research on ethics is located at the intersection of philosophy and critical sociology within the field of public health ethics. After our panelists provide their opening remarks, we'll address as many questions as possible in the limited time we have. You can direct questions you'd like answered in the Q&A function of this webinar, or if you wish to remain anonymous, please email lori.balchak@utoronto.ca. This email is also being shared in the chat box. So without further ado, I'll turn things over to our first panelist, Sally Bean. Sally.
Great. Thank you so much, Max, for the kind introduction. And it's a great honor to be speaking on this panel in honor of Ross and all of his achievements in public health ethics. So thank you so much for the invitation. I'll start with a little bit of a personal story. Early in the pandemic, I was supporting an end-of-life case, which isn't something that out of the ordinary for me, but in this particular case, it was shortly after the lockdown had started, and we were only allowing 2 family members at the bedside for patients at end of life. And so in this particular case, the 2 family members were at the bedside and the other family members were on Zoom, and they were saying their goodbyes over Zoom. And so it was simultaneously both haunting and uplifting to see that occurring, haunting because it had to be done virtually, that they couldn't be there to do something that you think of being so fundamentally an in-person encounter, or ideally, but uplifting that they had the option at least to do it virtually. And so, that was an early encounter, and certainly that's a microcosm of things that have happened throughout the pandemic. And while it may not be a flashy topic in public health ethics, I do think that hospital visitor policies, to me, really tells the narrative of the impact of the pandemic over the course of the last year. It's really the sum of individual narratives, situations where healthcare providers are surrogates for family members, things have to be done virtually, all that type of thing. And so I think it really, the visitor policy issue is really the quintessential public health ethics issue, and that you have individual and collective interests potentially in tension in this situation. And we know that in the best of times, having open and flexible visitation for our patients is extremely beneficial, has lots of positive benefits. So no one can test that. But in the context in which we currently find ourselves, that's not something that we can do. And so, having this ethical tension between certainly accommodating patient and family-centered care and promoting general public health objectives due to social distancing requirements, among many other things. So I've been the co-chair at Sunnybrook of our visitor task force since the beginning, and also I'm the Toronto Region Ethics Rep on the COVID-19 table. And so I've been involved in this work from the outset. And I think the mental image that I've had throughout has been really a tight rope walker. So really trying to balance those collective interests of both, the individuals, of course, staff, and collective interests on the other. I really think of the bar, if you will, as that of advocacy, and I have kind of 2 potential ends or objectives and intention that I'm trying to balance. And so it's an ongoing challenge, and you're not going to make everybody happy. So that's really something that I've felt quite persistently throughout the pandemic. At the Toronto region, they did issue some guidance really to foster standardization across hospitals in the GTA in terms of having a consistent ethical framework, patient categories, so things like end of life, birthing mother, those types of categories, of course, minors under the age of majority, those types of things, and then had corresponding recommendations for visitation based on patient categories, and of course an appeal mechanism. And so you're already starting to hear lots of really important ethical themes coming into play, even talking about those procedural and substantive elements. So of course we had the Toronto region guidance, and then that had to be adapted locally into a policy and implemented. And so, locally, we integrated 6 ethical principles, some of which were derived from the Toronto region. And I'll just name those. Compassion was really our first orienting value. Equity, minimizing harm, proportionality, reciprocity, and transparency. And so I'll just speak about a few of those. the proportionality piece, I think, is particularly important to remember that restricting visitation is an extraordinary measure. And so restriction should be the least restrictive to promote public health and safety objectives, and certainly only as long as required. So really making sure that there is that clear connection between the risk of harm and the restrictions. So I think that piece is quite important. Another one that I think really stands out for me is reciprocity. So for our patients that can't have visits from their family members, trying to mitigate that burden. So having a very robust virtual visitation platform for them and was a key element of that. And naturally, there's inherent limitations where virtual platforms are not going to be conducive to all patients. But really focusing on those ways of mitigating harm. And throughout the pandemic, I'm on the appeals committee, and so I do hear a number of appeals every day for requests for augmented visitation from patients and their families, and some of them are quite compelling and gut wrenching. And so, from a procedural fairness standpoint, you of course want to be consistent and treat like cases alike. So all those types of things have really important ethical themes that we have to follow from both a procedural and substantive point of view. So I'll pause there and look forward to further discussion.
Thank you so much, Sally, for those remarks. And for those learning about public health ethics, one of the main themes that distinguishes public health ethics from medical ethics or medical ethics or bioethics is really that population health ethics thinks about those collective actions that are taken for population health. But what's often not really emphasized is the impact this has on local institutions and how this plays out in local institutions. So it's really interesting to hear your remarks about exactly what this looked like at Sunnybrook. So thank you for those remarks. Next up, we'll turn over to Dr. Brian Schwartz for his remarks. Brian.
Thanks, Max. And again, just to thank everyone for coming and for inviting me to serve on this panel. And it's an honor to be able to serve on a panel in honor of my good friend Ross Upshur. So my intention, I'll talk a little bit about an example and maybe start by reminding everyone that I work for Public Health Ontario. And Public Health Ontario is a Crown agency. The purpose of the Ontario Agency for Health Protection and Promotion, which is our legal name, as set out in legislation, is, just get it here, to enhance the protection and promotion of the health of Ontarians and to contribute to efforts to reduce health inequities through the establishment of an agency to provide scientific and technical advice and support to those working across sectors to protect and improve the health of Ontarians. It's a mouthful, but that's my job as both a scientist and an employee of a Crown agency. And as Max said, I also serve as the co-chair of the Science Advisory Table for Ontario's pandemic response. And that's congruent with my work at Public Health Ontario. My job is to evaluate and communicate science. But during this pandemic, we're in a place where science is evolving rapidly. And at any given point in time is a snapshot. It's not very clear. And it's even more difficult to explain, both to the public, but more importantly to decision makers. For those to whom we provide our scientific and technical advice, there are lots of elements of decision-making beyond the scientific evidence that come into play, such as legislation, the economy, politics, ethics, and values. And in the absence of clear and consistent evidence, those other factors are even more relevant. So I'll give you one example. One of the key drivers of the COVID-19 transmission is workplace outbreaks. They usually occur in essential services like food production, agriculture, warehousing, transportation of goods, and long-term care, as we know. We also know that many workers in these industries, most workers in these industries, are not well paid. They have few or no benefits. They live in crowded conditions very often and are from racialized communities. They can't work from home, obviously. They need to travel on public transit. And most importantly, are not willing to miss work when ill or exposed to the virus for fear of losing income. The federal sickness benefit does not even cover minimum wage. I think it's short by about $100 a week. And it also takes time to access. The evidence that supports paid sick leave policies during outbreaks is not that rigorous. It's limited to case studies, extrapolation from other infectious diseases, such as seasonal influenza. There's a fair amount of work that's been done on absenteeism during seasonal influenza, less so in the coronavirus pandemic. And what work there that has been done in the coronavirus pandemic has been done in other jurisdictions, primarily the United States, Australia, and some parts of Europe. So we have to extrapolate from those experiences. However, many of the arguments supporting paid sick leave flow from ethical principles. And Sally's enumerated some of them that are relevant to her practice at Sunnybrook, but they include protection of the public from harm. I mean, clearly, it's an imperative to isolate people who have been exposed to the disease or who have symptoms. Equity, as I've outlined, many of these people are from low-income, racialized populations. Reciprocity, our duty to care for people who are caring for us. Proportionality, and solidarity, that we're all in this together. And while scientific and technical advice should inform these decisions, so far, our work on paid sick leave has not changed policy, at least up until now. So what's the ethical tension? Well, firstly, as a scientist and Crown Agency employee, I have an obligation to report objectively on evidence and apply it to the Ontario context. I also have a moral duty as a physician scientist to be a health advocate. Here's what CanMeds describes as the health advocate role of physicians. Physicians are accountable to society and recognize their duty to contribute to efforts to improve health and well-being of their patients, their communities, and the broader populations they serve. Obviously, in my case, as a former clinician, it was my patient. Now my patient is the population of Ontario. But more than that conflict, there's also a very practical tension. If I fulfill my obligation as a Public Health Ontario scientist or a university scientist, and I report objectively, and I don't rock the boat, I maintain credibility with decision makers as an objective and trusted source of knowledge and information. And with that credibility comes influence, which is crucial for every issue that we bring to policymakers. It also keeps me in the game in case a policy window opens for this particular issue or another one. If I fulfill my duty as a physician scientist and advocate, then I may be perceived as a critic of government policies and values, and therefore risk losing that credibility and influence. And finally, if I simply search out the science that I want to support my original position, have I then moved from being a scientist to being an advocate? So I think it's possible to live in that space. It's probably necessary to live in that space as both a scientist and an advocate. But as Sally put it so well, it is like walking a tightrope. So I'll leave it at that for now, and hopefully we'll come back to some of the ways that we can resolve or manage some of those tensions. Back over to you, Max.
Thanks very much, Brian. Fascinating remarks. And certainly we're all trying to navigate this tightrope together. And one of the themes that hopefully we can pick up on later is this question of credibility and credibility in science in your role with PHO and the Science Advisory Table, but perhaps even thinking about credibility in public health ethics and what that ought to look like. So thanks, Brian, for those very, very nice remarks. So last but not least, I'll turn it over to Professor Alison Thomson for hers. Ali.
Thanks, Max. And thank you, Brian, for setting up what I wanted to say very nicely. And I hope to pick up on some of the themes that you have drawn out. And I offer these remarks with a little bit of trepidation because it feels a little bit like self-indulgent navel gazing while Rome is burning, to be asking questions about, how ought liberal democracies to make use of expertise, and in particular, bioethics expertise. I think most people are aware that reliance on expertise in a democracy is problematic because it's it's a technical reliance that is sort of anti-democratic depending on how it's done. So I want to reflect a little bit on that and ask, as Brian has, what's the proper role of science in policymaking? And Brian has very nicely outlined that, especially for scientists who are also physicians and have obligations to the profession as well. And then what is the role that bioethics plays in responding to a health crisis that affects not just our own families and our colleagues and our cities and our provinces, but the entire globe? So unfortunately, I'm going to restrict my remarks to my work in the bioethics community in Ontario. But there are so many substantive ethical tensions we could be talking about. But forgive me for focusing on a little bit of introspective reflection here about the role for public health ethics in particular. So I think what's been remarkable about this experience for many of us who have been involved in pandemic planning for many years is that substantively there are not that many new issues that have been surfaced by COVID-19. A lot of the work that has been done in the past is highly relevant to what's happening today. And as Ross Upshur himself likes to say, we either have, sort of collective amnesia or collective narcolepsy, failure to learn the lessons of the past. And I believe, Max, you may have contributed to that paper too. But, what is new, I think, for many of us working in public health ethics is that we are being invited to make substantive and procedural contributions to bioethics policy through real-time advice being given to governments that's been invited, whether that's through the COVID-19 bioethics table that's advising the government in Ontario, or the work that I've been doing with colleagues in Germany, or the work that Max has been doing with the WHO. These are somewhat extraordinary experiences for bioethics. This is not a royal commission. This is not the president's bioethics commission in the States. These are real policy receptors or windows, as Brian said, that may or may not be open, but that remains to be seen. But this is a new experience for many of us. And it's given bioethicists a power and an access to politicians that is possibly unparalleled. I wouldn't want to stake my life on that claim, but it's certainly unique experience for many people who are working in this area. And it's tempting to see this as a real triumph, like, I finally made it, I'm talking to Doug Ford, or we're at the big boys table. And it is significant that there has been widespread acceptance that bioethics has something to contribute here. And that's exciting. But I think it's important. Renee Fox and Judith Swayze asked many, many years ago, what ought we to do then about the fact that bioethics, like Mr. Smith, has gone to Washington? So what do we do about the fact that bioethics has gone to Queen's Park? And I want to share a high-level overview of some of the experiences that we've had at the bioethics table. You know, is this the ultimate sort of legitimization of bioethics, or, you know, has something else happened here that we need to be a bit wary about and reflect on? So at the beginning of the pandemic, around this time last year, the bioethics table began working alongside some of the other COVID-19 advisory tables for the Ontario government on a critical care triage framework. We proposed some an ethical framework for how to do that, and some substantive recommendations. And long story short, you know, there was a lot of mistrust generated by this, and, you know, there may have been some missteps procedurally about how to go public with this framework. And we have received a lot of criticism in the press for not being transparent, and a lot of criticism from the disability rights community and from the human rights community, from Indigenous health leaders and from the Black health community, about not just about how there is a potential for discrimination in the triage framework itself, but also about the procedure which we have followed. And, you know, we do have, you know, I'm not speaking for every member of the table here by any means, but, you know, there are, these concerns have been addressed, I think, very conscientiously by the table, but we've been forbidden to discuss the content of our work that we handed over to the government. And despite pleas for this to be made transparent and for further engagement to be led by the government with these stakeholder groups, that has yet to happen. And we are, you know, this is becoming more and more problematic as ICUs are beginning to look like it's an entirely possible situation where they will have to implement triage. And so, you know, this experience has caused all of us on the bioethics table to take a moment and pause and reflect on the kind of expertise that we are offering and what we are willing to do in order to keep a seat at that table. And that's not just self-interested, that's because there are people we have now partnered with who we think it's important to give that power to, or to share that power, if we actually have any to share. So I think all of this has raised some really important questions about what we're doing when we're doing what we're doing, when we're advising policy makers or governments as bioethicists. I think it's become clear that we had failed to become accountable to the public for our work by waiting for the government to go public with those documents. And, you know, it's been an interesting process to figure out how we can further the public conversation about critical care triage without burning that bridge with government. And what's the role for other moral agents in this conversation? You know, they are not bioethicists, but do we offer them a seat at this table? What kind of moral expertise do they bring? Was it our job to engage with a variety of stakeholders who felt they were going to be negatively impacted by this, or is that a distinctly political responsibility? Do we keep quiet about what's in this proposed framework and how we came up with it? Or do we go against what the government expressly asked us to do numerous times and, you know, release these documents publicly? Do we allow the press to continue to misportray our work? And, you know, ultimately it's reputational damage to the bioethics community, I think, that we have sustained because of this. You know, but the cost would be here, you know, are we risking our advisory position with the government and the power that comes along with that to make recommendations? And as Brian has pointed out, perhaps our credibility with the government, but not the public. You know, so are we forced to choose between our public credibility and our credibility with the policymakers? And so that's a lot of issues to raise, but I think ultimately the real question here is what kind of authority do we have as bioethics experts, and how ought we to use that? And so I think that, you know, bioethics is so different from science in that we don't have an epistemic monopoly on moral issues. You know, we're not the secular clergy. And this is a real difference between scientific authority and bioethics authority. And I think that, you know, part of the problem here has been that government has, you know, and many people in the public and even ourselves at times, we forget this. And you know, the problem with that, technocracies can take hold and reframe some of these, what are ultimately social and moral problems, as technical ones, and exclude from public policy discussions that sort of broader moral perspective, because it's not part of the legitimate locus of interpretation for experts, you know, that. And so bioethics is not the same kind of endeavor as science, and it doesn't really have this epistemic monopoly on ethics, and it doesn't have the authority that scientists do to make recommendations in the same kind of way in the technical phase of policymaking. So what does all this mean? Well, I think what that means is that we have some thinking to do about how we can redress some of these issues. And so if we wanted to talk about it as expert failure, you know, and as expert failure being defined as what happens when the normative expectations that are associated with the expert's advice are deviated from, then I think we need to ask ourselves, what does expert failure look like for public health ethics? And, you know, part of this has to do with how we justify our recommendations. And I won't go into a big philosophical discussion about that, but I think this experience has made it even more important to have that discussion, because I think ultimately the best way that we can justify our policy recommendations is to ensure that the sort of ubiquitous moral expertise that everybody has just by virtue of being a moral agent and having lived experience, as opposed to experience that's pulled from theory, we need to engage with those publics that are primarily affected, but we also need to have a broader public conversation. And until that happens, bioethics expertise and any recommendations that comes from it is not really legitimate. And so what do we do when a government fails to recognize that and would like to just rely on a sort of scientific notion of expertise and authority to be able to say, well, the bioethics table told us to do that this way, you know? So we have a problem with accountability to the public, and we also have a problem with how our expertise is being relied upon by government here. And so I have some thoughts about what we can do to make sure that that doesn't happen, but maybe I'll save that for the broader conversation that we're going to have in a minute. Thank you.
Great. Thank you, Alison, for those comments. So much to chew on there, and always good to leave us hanging for the solutions. So we make sure we come back to that. So I just wanted to remind everyone online that you can submit your questions through the Q&A function, and we'll let those sort of percolate now that you've heard from our three panelists. And in the meantime, I was wondering if we could just provide a brief opportunity for our panelists to respond or react to any of the remarks from their fellow panelists. There was a lot there, and so I wanted to give you the first crack at responding or reacting to anything that you may have heard.
Well, maybe I'll start, if that's okay. Maybe I'll go back to Sally. One of the things I wondered about as you were talking about your experience on the front line is you talked about, you know, the conflicts and the ethical tensions. From the staff perspective, when the staff are being asked to be surrogate family members, try to put myself in their shoes. What are the ethical issues that they struggle with, that they've talked to you about, and how best can ethicists frame those to help the staff manage those ethical issues. For example, if they're asked to do something for a family member that they are not in total agreement with, because of a specific need of the family member and in a specific kind of culture.
Is it okay if I respond briefly, Max? Yeah, so great question, Brian, in terms of how did the staff respond to being put in the shoes of potentially being a surrogate family member? And I think it raises lots of really important ethical issues. Of course, professional boundaries being one, and being pushed beyond your comfort level or even what might even be appropriate. But there's also, I think, from the narratives that I've heard, a lot of moral trauma from this. Just feeling very burdened by the fact that they had to do it, but also felt that it was a privilege that they were able to do it, right? So I think that, I don't want to say it's all bad, but I've certainly heard from a lot of people that they were really happy that, if the family couldn't be there to hold their loved one's hand while they were dying, that they could be there to do that and honor that person and convey that message. So, it's really lovely to hear those stories, but there are so many ethical issues bound up in that. And I do think that moral trauma of taking on this additional role and additional burden is something that we're going to see in the aftermath. And of course, we're already seeing it now with burnout. But it is something to think about in terms of supporting healthcare workers and other essential care providers that are put in similar positions.
Thank you, Sally, and thanks, Brian, for that question. Ali and Sally, do you have any reactions, remarks you'd like to make from the panelists' remarks before we turn to questions?
I'll just maybe say briefly, I thought, there were such interesting themes brought up in each of my co-panelists' sections. I really thought the cross-cutting notion of credibility was quite interesting in terms of what that looks like as a scientist versus an ethicist. Brian talked about objectivity in terms of science, and the outcome of that was credibility and being able to do good, for lack of a better word, and advocate. And so, naturally, I started thinking about what that looks like in the ethics context. What's the equivalent there? And Ali used the word legitimacy, right, which is one that we use quite a lot in ethics in terms of fair process and procedure. So it started me thinking about the connection between the two and that moral authority as well that Ali referenced. So I look forward to hopefully hearing some thoughts and comments from others in the audience about that.
Thank you, Sally. So I do see there's a few comments and questions that have come in now, and I see one that seems to pick up on this thread quite nicely, and this is from Lina Lee, who's wondering about what the panelists feel about the use of ethics as a tool for advocacy by groups with special interests. And here, I suppose we might think of special interests quite broadly. And Alison had mentioned some work with the disability rights advocates and the Ontario Human Rights Commission, but of course, there are many interests out there, and some of those will be stronger interests than others, or might be louder than others. So I'm curious to hear the panelists' thoughts about the use of ethics as an advocacy tool. So anyone that wants to pick up on that, please. Yeah, Ali, go ahead.
So, I think this goes back again to this question about how do we justify the kinds of claims we're making as bioethicists, or the kinds of policy recommendations that we're making. And certainly, I think that for bioethics, one of the, advocacy ethics is certainly a form of public health ethics. And I think that when a bioethicist kind of goes in-house and is making recommendations or amplifying the voices of or aligning themselves with a particular group of individuals, or whether that be Indigenous health partners or the disability rights community or just human rights in general, I think that that their claims are at least democratically and justified, because they are representing, a group of citizens and moral agents. And so there's the justification for that kind of work is perhaps different than the kind of justification that would be required for, say, the bioethics table, It may be part of what justifies a bioethics table recommendations, but I think, I think that's certainly a legitimate way to do bioethics, is to sort of go in-house like that. And, the justification for the claim that they're making, or the argument that they're putting forth, really relies on, this sort of democratic, representation of this group.
Thanks, Alison. Sally, Brian, any thoughts from you about the use of ethics as an advocacy tool to perhaps address or promote special interests? Yeah, Brian.
You saw me on mute. Yeah, I don't know. I guess the question is the difference between being ethical and being moral. They're trying to make an argument, I think, on the morality of their cause, and to me, it would seem that an ethical lens would be the one through which you would assess the morality of that cause. So, on what basis is it made? Is it made on equity? A lot of times, it is. Because of so-called disadvantaged groups that do not have the opportunity to access in this case services or benefits that the more privileged have. And so, on what basis would these claims be made to the rightness of this claim about what ought to be done? So I think ethics could be a lens. In listening to Alison previously, I kept thinking about the term, the sort of the secular clergy and the moral authority, and looking at scientists as a moral authority to say what should we do. It's a tough one, and looking at ethicists as a moral authority. It's my understanding of ethics, and I'm not an ethicist, is it's defining the procedure by which you access that moral authority, whether it's in the public or whether it's in decision makers or wherever it may be. So I think I would say that the ethics lens would be to analyze and assess the claims of these groups that are making those claims on the basis of quote unquote ethics.
Thanks, Brian. Not being an ethicist, you've made a very astute observation about how we might go about doing this. So thank you for that. Sally, any remarks from you on this particular point?
Sure. Just briefly. I mean, I think sure it's a legitimate risk that your work could be misconstrued or twisted, and I think that's always the frustration if it is misconstrued or misapplied. I think we commonly see equity and equality being conflated, for example, where someone might take an equity argument, for example, and say that that really means equality. So I think those types of things you see a lot, but it also, to me, really emphasizes the requirement to be very clear in my communication and make it accessible to try to minimize that potential as much as possible. But it certainly is something that's always a possibility in terms of what could be done with your work and that type of thing. So I always have that in my mind about how will this be wielded or potentially used. And that doesn't craft the message per se, but I think it's really that communication piece that's so valuable in terms of thinking about that, and can honestly help you refine your argumentation a bit too if you think about those potential misuses that might occur.
Great, thank you, Sally, and thanks, Lina, for that question. Another question raised here by Julie Lee is, isn't it a big problem that there's not necessarily consensus among bioethicists regarding the right or correct view or approach to any given situation? And Brian, even though you say you're not an ethicist, I'm willing to throw you in that camp, but we might also extend this to scientists, right? That there isn't necessarily a consensus view about what we ought to do from a scientific perspective. And if I can just add, as an academic, it's very easy, well, it's not easy, but it's more straightforward to problematize and, address considerations or raise considerations. But as a clinical ethicist or someone advising government, you feel the need to provide a recommendation and not simply lay out the facts or the arguments that might be on the table. So panelists, what do you think about the problem that we have, that we don't necessarily have consensus on what is the right or wrong way to go about certain things, either from an ethical or a scientific perspective. Yeah, Alison, please.
I would say that I think that it's a problem when bioethics has to provide coherent like recommendation for action, and you know, this is where I think that bioethics gets into trouble when they are too closely coupled with the policymaking process, because in fact, I think consensus is a disservice in those situations. I think that there is a very important role for dissensus. And when we strive towards a singular recommendation that, you know, is purportedly made on the basis of, you know, committee consensus, you know, that's again using bioethics authority to confirm some kind of legitimacy on a policy option or a recommendation that really isn't warranted, because when we see those kinds of recommendations that are consensus-based, we often see a narrowing of policy options, a narrowing of the interests represented or weighed in those decisions. And, you know, to keep the moral discourse legitimate and vibrant, we need dissensus. We need to be open to reframing the policy question itself, you know, and that doesn't happen when we're driving towards consensus all the time. So I think, you know, we're not very helpful when we're all at 6s and 7s about something. But I think if you think about bioethics as setting the stage or shaping the public conversation that will legitimize a policy decision, it is really important for us not to, you know, prematurely narrow that conversation and focus on driving towards consensus too early.
Thanks, Alison. And Sally, I'm wondering at the institutional level, at you know, being in a hospital where decisions must be made, and you know, the visitation policy is a great example of one where, you know, you can't just not make a decision. There's good arguments on both sides here. There's data on both sides here. How do you navigate the fact that surely even amongst your ethics team and surely amongst the senior leadership at your institution, you don't have consensus about these issues? So how do we move forward with an actual way of doing something given that context?
Thanks, Max, for the question. I think it's helpful at the outset to outline how decisions will be made or recommendations will be made, right? So are you aiming for consensus, or if you're not able to achieve that, is it going to be you know, basic majority rules, that type of thing? So I think having those discussions in advance is quite helpful, whether it's in a terms of reference or just a stage setting exercise. That's really important, because you're quite right. We do have to reach a decision to be able to move forward, and you know, consensus isn't always feasible, but being clear about how we will resolve it if that's not achievable.
Yeah, I think that's a great point, and both questions have been great questions. A couple of reflections. One is, you know, to me, you know, we've always learned that a good scientist is not one who has the answers. A good scientist is the one who knows how to frame the question. And it's really, you know, my other reflection is, as a co-chair of the Science Advisory Table, you know, it's really, really hard to get consensus. And in fact, you know, sometimes you kind of have to artificially make, even on the science, when you're really not making a final decision, but just to take something forward to a policymaker, for a science brief, it's to reach a consensus that is livable and that is defensible and accountable. So going back to my clinical days as an emerge doc, you know, operating with incomplete information and making a call is really, really important. The important thing is not to err on the side of, you know, total precaution or total risk taking. It's really making a decision that's prudent and that's defensible and accountable. And going back to Alison's comments, is transparent. And if we're, especially in a pandemic, if we're wrong, we're wrong. And even the ethicists are going to be wrong sometimes. And to be able to live with that and be able to say, this is the best decision we could have made. Let's move forward.
Thanks, Brian. I'm wondering that, the bioethics table, just as the Ontario example, and the science advisory table obviously do not constitute the entirety of those fields. And of course, there are a lot of bioethicists who aren't in the position of advising governments, who are very free to be critical and be very loud. And similar with the scientific community, we see a lot of scientific data and advocacy from scientists that might be able to speak more freely or push particular agendas differently, or at least in a different way than those that might be advising governments directly. Do you think that that is a satisfactory way for this to fall out, that those that are in these advisory positions can remain perhaps a little bit more neutral, if we can think of it that way, knowing that there is a broader community of bioethicists and scientists who are more capable perhaps of raising those issues in the public discourse?
Maybe I'll start on this one. I mean, it's easy for me to sit here and say that Discord is a wonderful thing, and public discourse is also great, and in theory it is. In practice, sometimes it's a little bit more difficult to manage, especially when some of the criticisms are become more personal, which is difficult and should be off limits. But that aside, I think it is important for that discourse to occur. But again, to understand that, and in defense of confidentiality, seeing the other side, that many discussions within government need to take place behind closed doors, so that people, the decision makers, can freely articulate their discussion and come to a final decision, which may or may not be popular, and will be popular among some and unpopular among others. And the more credibility one has in their advisory role, the closer one can get to those decision makers to be able to influence. So there's, everything has its price, and the price one pays for getting close sometimes is confidentiality, and the price one pays for being outspoken is not being as influential as perhaps one would like.
Thanks, Brian. Alison?
I think that's a really great question, and I think Brian's articulated the tension really nicely there. And I would just add that when part of the challenge here is to determine, you may be close to the policymakers. You may, in fact, think you have a really good relationship with them, and maybe you do. But I think ultimately we have to step back and ask, do we have any power here? Ought we to have any power? And I guess one of the issues that we've been wrestling with is, do we, for people who are tempted to quit and become that, gadfly from the outside, which is very tempting, I have to say. A lot of the time, part of the argument for staying is that we owe it to our partners in, the human rights community, the disability rights community, Indigenous partners, and Black community partners. We owe it to them to stick it out and to include them in this table and to share that power with them. And my concern becomes, when is that a sort of false empowerment? Are we deluding ourselves that we're actually, we're the bioethics table, but do we actually have any power? What have we accomplished? That's very hard to say. It's very hard to quantify. It's very hard to show. And at the end of the day, are we building trust with our partners, or are we potentially undermining it? It's really difficult, and I think we have to beware this very simplistic approach to empowerment through access to these tables. I think it warrants very careful consideration about not just the composition of the table, but what are we claiming to be able to accomplish here? And in fact, is it actually better for us than to be advisory, to become a stakeholder that needs to be managed? Maybe that's better. But I think you're right. There's probably room for both. And you've got the Martin Luther Kings and you've got the Malcolm X's. Maybe, I don't know. That's there's room for everybody probably to make a contribution.
Thanks, Ali. Sally, any thoughts from you, or do you want to jump to the next question?
We can jump to the next question. Thanks, Max.
Okay, I'm just recognizing there's 6 more minutes, so hopefully we can squeeze in 2 questions before we end here at 5 o'clock. So Jed Gross has asked an interesting questions about the incorporation of value-laden concepts like justice or equity within the charges of government-appointed expert panels. Is this something that you think is possible, a good idea? I mean, Brian, you had mentioned that part of the mission of Public Health Ontario is the reduction of inequities. And of course, within that is something that is value laden. And so I guess the idea would be about making that more explicit and what that commits us to from a normative perspective. And perhaps, Brian, I'll put you on the spot from a science table, which is meant to be achieving a mission, which is the reduction of inequities, perhaps, or engaging with those sorts of ideas, which are ostensibly meant to be seen as a neutral approach or objective approach to it, despite the fact that there are values baked into that. How might we think about doing that?
Okay, well, I don't have all the answers, but I'll start with 2 thoughts. Number one is, there is recognizing the different kinds of science. I mean, as there is a science and a body of knowledge, maybe that's better described, in justice and equity. And certainly that's what I've learned from the bioethics community, that it's not science and not science. And notwithstanding Alison's comments, there is it's a qualitative science. It's a science that we scientists have not grown up with, especially those of us in clinical services, but it has weight and it should have authority and it should be part of our construct in what we do. Now, the tactics of that are open because some of those are laden with politics. And then at the end of the day, in the absence of that quantifiable science, I think the values are very important in making decisions. And you could see that in any democracy, that a democratically elected government will come to power on the basis of certain values and a certain populist appeal of those values. And for better or for worse, we live with that. And it's we can inform it, but ultimately, we the people have elected certain officials and given them the responsibility to bring those values that we have at least indirectly supported to the table to make those decisions.
Thanks, Brian. And Alison and Sally, as members of the bioethics table, we have identified things that we want to do in thinking through the ethics of particular issues, and perhaps sometimes try to lay those in front of decision makers in a somewhat dispassionate manner, so that those could inform decision making. What do you think about setting out as a bioethics table to say we are explicitly committed to the correction or remediation of racial injustice? And so the work that we will be doing will be furthering that aim as a core objective of what a table that might be advising government might do. Do you have any thoughts about the prospect of doing that, if that makes sense or is workable? Or is that something that's embedded, perhaps even just implicitly, in the work of a group of bioethicists that are advising a government, and perhaps maybe it should be made more explicit what the explicit normative aims of such a table might be doing? Yeah, Sally, go ahead.
I was just going to say, I mean, they're all really, really excellent questions. And I think taking a step back as well and thinking about the composition of the table, right? And how did they get there, and who's missing at that table, I think is such a key element. And I think we're also much more attuned to privilege and racism, structural racism, and all those types of things. So appreciating that there are a lot of views missing at I'll just kind of use a hypothetical table. So I think having appreciation of that is really important as a starting point, right? And hopefully being able to supplement membership to capture some of those voices that might not be represented is an important first step, in my opinion.
Thanks, Sally. And something perhaps where there is closer to consensus amongst the bioethics community about doing, which not to say that everyone is in agreement, but certainly closer to consensus than we might have about certain substantive issues. Alison, any remarks, thoughts about that before we wrap up?
I guess it just goes back to this question about what are the normative expectations of bioethics experts, right? And certainly I think personally, and I think as a table, we've really been wrestling with that. You know, we've had a few conversations now, you know, we have a terms of reference, but, you know, I think that question is somewhat up for grabs. And I think that, you know, perhaps we need to look at what makes us legitimate experts. Where do we draw our trust from the public? You know, we are funded by the public, our research is funded by the public, we are accountable to the public. And so, you know, what are their normative expectations of us? I think at the very least, it's to not act in an untrustworthy way. And so that may mean taking up certain normative causes or normative positions and constructing tables in particular ways so that voices can be heard, so that sort of ubiquitous moral expertise is in conversation with bioethics expertise. But how to do that is ethically fraught, I think, warrants a whole panel by itself.
And if I can just do one follow-up, Max, to clarify something. Yeah, you know, just because we have a democratically elected set of decision makers, it does not preclude us from seeing issues with justice and equity that we should continue to bring to the table and to advocate for in whatever way we can, and that is in whatever avenues are available to us.
Great, thanks for those remarks, everyone, on that last question. And certainly I think that provides a little bit of a renewed mission moving forward, because unfortunately we're not quite out of the woods yet with this pandemic. So certainly there's still opportunity to improve. So we are at time, and I wanted to, I've noticed a comment from Ross, our named, the person for whom our lecture is named after. So Ross, thank you very much for joining and for your comment. Ross says, thank you, Max, Ali, Brian, and Sally, for your exceptionally perceptive observations and for taking time from your very busy schedules to contribute to the Upshur lecture. And I'm sure I speak on behalf of everyone on this panel, Ross, where we say it is our pleasure and privilege to be involved in such a lecture. So thank you to Alison, to Sally, and to Brian for your time and very thoughtful remarks today, and engagement with the questions that we received is very much appreciated, very stimulating. And thank you everyone for coming to the Upshur lecture, and we hope to see you again next year. Thank you, everyone.